When looking at continuing passive motion with, again, contraindications, precautions when we would use it, the contraindications are obviously any unwanted joint motion and the associated stresses on the bones and the joint structures. That's the main contraindication. So if we have fractures that are undiagnosed, or if the joint is particularly unstable and motion would be contraindicated, we don't do it. So unstable fractures, uncontrolled infection, spastic paralyses as well. If someone's prone to spasticity, you don't want to be locked in the continuous passive motion machine. That could cause more damage. Precautions, history of deep vein thrombosis. Again, we use continuous passive motion most often post-surgical, which is a risky time for DVTs. And so if someone has a history of DVT, sometimes this motion can break free some of those blood clots. And so we wouldn't want that to occur. And so we'd want someone seen, and we'd want to, again, it's a precaution, we'd want the physician's prescription to use the CPM. And then the other precautions is the type of CPM, the motion you set, the speed, all that needs to be adjusted to be appropriate for the patient. And so it's usually based on the physician's recommendations for whatever pathology is being treated. We don't want to go to extreme ranges of motion if that's not proper for this injury. We don't want to have that joint free, like in a free linkage, if the joint is unstable. So there's just lots of kind of idiosyncrasies that we want to be aware about. So looking kind of overview of the evidence, nearly all studies conclude that there's not any significant long-term difference in either pain or range of motion between patients who received post-op CPM and those who did not. So the decision to include the CPM in the early treatment protocols really look more so at the immediate benefits as well as the long-term, but you also weigh them to the potential hazards, so the contraindications and precautions especially, and the associated costs. CPM machines aren't cheap, and so if you don't have one in your facility and the patient is being prescribed it, then it gets billed to insurance, and that's maybe not the most efficient use of healthcare dollars. So there's a lot of efficacy questions. Is it more beneficial than just manual therapies, passive range of motion with the clinician? And it seems to not be. We have the theories behind why CPM should help, especially on the healing cartilage, but there's a lack of quality controlled studies, randomized clinical trials done on CPM to really look at that. So CPM is most often used following total knee arthroplasty, and that's a lot of the focus on any retrospective and prospective investigation. So most of the studies are on that, and that seems to have some benefit in decreasing hospital stays, decreasing the need for pain meds, earlier active range of motion like straight leg raises, improving function kind of over time, at least at the time of kind of discharge and early on in the process. Reduce the need for knee manipulations and joint mobilizations post-surgery with this. But again, in our world, the research is much more mixed when it comes to the treatments and the conditions that we would more likely be seeing in our patient population. So when we look at a CPM machine, and you'll have kind of a video showing you that, the instrumentation can vary, so you got to know your machine and refer to the manual for your machine, but there's almost always a power switch, right, that turns it on, a reset button that would clear all the previous settings, the timers to set the duration of your treatment, and usually you can set a continuous as well as sometimes there's kind of the duty cycle within it for those long-term treatments. You get to set the range of motion, which usually goes from kind of slight hyperextension, maybe about 5 degrees, to full flexion, about 30 degrees. Some machines you control the flexion and the extension separately. Sometimes you just set that arc. And so you would again need to know what your restrictions are for your patient. There's a speed button. usually between 10 to 120 degrees per second. So again, if you're thinking that full flexion is 130, if you're up at that highest speed, you're getting through your entire range of motion in about 1.5 seconds. If you go slower, down to 10 degrees per second, that is taking you, 10 seconds or longer to get through your range of motion. So slower speeds are used usually post-surgery or immediately post-injury, and then you increase the speeds, so the cycles per second, in order to produce better tensile properties as that tendon heals. You should be getting more of Wolff's Law, more strategic adaptation as the tissue heals. The deceleration, acceleration, this adjusts the number of degrees per second the joint accelerates at the beginning of the motion and decelerates at the end. So you set that speed to go throughout, but we know that we're kind of weakest and more vulnerable at the very beginning stages and at the very end stages of the motion. And so we can actually set how we accelerate through those phases a little bit different to, again, help to control the motion and make it more comfortable for the patient. The TERT is the total end range time, so it's the amount of time the joint is held at the end of flexion and the end of extension. So again, we see some benefit of staying at those end ranges for a little bit before we move through the next motion arc to kind of increase that potential for range of motion gains. There's always a pause button, and that allows for that extension flexion delay. So stops the motion at the extreme range of motion to allow passive stretching of the fibers to occur if that's something we would want with our patient. An interrupt switch, so the patient can stop the treatment at any time. The trigger jack allows you sometimes to synchronize the CPM with like Russian, so with electrical stim. And so it would allow the neuromuscular electrical stimulation unit to be activated during those pauses at the end ranges of motion so that you could be working some ideas of regaining that neuromuscular control. And then there's programs, so where you could actually set programs for various patients, so you'd only have to hit one button kind of every time they come in. So we're going to prepare our patient. We always check our contraindications, clean the body part, and figure out the fit. So usually this is done even in the recovery room after surgery by a CPM technician. So the protocols would depend on what the condition is, if it's post-ACL or meniscal or what it might be, things like that. Or if you're on a different body part like shoulders, those take longer setup because you have more ranges of motion you have to consider, things like that. So we measure to fit the body part we measure if this is for the knee, measure the length of the thigh from the ischial tuberosity to the knee joint line. And then we measure the lower leg from the medial joint line to about 1/4 inch beyond the heel, and we would place the pads and in the proper support for that. Usually we remove any wraps besides kind of the single layer or an elastic sleeve, a stocking net or something like that, just so that everything fits in the CPM the best that it can be. And then adjust our placement. So, align the knee, place the limbs so in unit so the joint line is aligned with the articular hinge so that we're lined up properly. Place the lower extremity in the unit carefully. Obviously they just had surgery or they're tender, so we want to make sure it's always supported as it's going into the machine. And adjust the foot so the tibia is neutral. You don't want the toe turned in and out. We don't want any rotation in the tibia, especially if it's a post-ACL surgery. So then we start our treatment. So we give the patient control, give them, the stop mechanism and give them their instructions. So give them the handheld control and tell them how to use it, including how they can adjust the speed and the range of motion, but also tell them what their limitations are. So usually we set the range of motion between 0 and 60 degrees, again, post-surgical, and it can progress to full range of motion as healing occurs and the pain has decreased. Again, you can usually give a range that this is where they have to stay, and then they can work themselves up within that range as well. We want to confirm that with a goniometer because the machines don't always give you complete accuracy. So especially depending on how the person has been positioned in the machine. So you want to double check with the goniometer, make sure we're staying in the proper range. Then we're going to set our speed. So again, is the cycle time about 4 minutes, which would be, 15 cycles per hour, whatever the program is kind of set for. Increase our range of motion at regular intervals as tolerated, so we can adjust that range of motion. We want to recognize that there's any pressure related problems from the straps or from the support bars. We don't want to get any sores, especially want to be careful over their incisions and make sure that the straps and things don't go directly over the incisions. You also want to give them actual written instructions if this is something they're doing at home, which is most likely. We use CPM kind of continuously for a long time. So they need to have those written instructions along with emergency contact number if something goes wrong. And then you also want to check for compartmental hemorrhage or DVTs, regular checks to make sure that they're not forming any post-surgical complications. And again, post-treatment, so the length of time would all be set on the physician. Some people can spend hours in the CPM at a given time. Others would have a couple, you're in there for about 30 minutes and then off and then back in. It just kind of depends on the physician's protocol. So after the treatment, you'd want to make sure that the carriage is positioned to allow the limb to be removed. So it's usually just short of full extension. You want a little bit of bend in the knee still. Loosen the restraining straps and the foot plates. And then again, carefully lift and remove the CPM unit. So someone needs to support the leg while the other person moves the unit out of the way. Remove the sleeve from the extremity. Look for any pressure sores. Check your pulses and for swelling, looking for the DVT or any compartmental pressures. Look at the surgical sites, the incisions, wrap those back up and wrap the knee however it's supposed to be cared for, so cleaned and cared for during that time. And then again, redress the surgical wounds, apply new sterile dressings, apply a compression wrap, whatever the protocol says. And then when it comes to maintenance on the machine, again, look at your manufacturer recommendations, but we disconnect the CPM from the power source whenever we're cleaning it. Clean the surfaces with like a disinfectant soap. You can even use what we typically use for our body, our bloodborne pathogens, right? A 10% bleach solution. If any blood or, pus from the surgery or things like that had gotten on the machine. Clean and replace the carriage covers, so any of the soft covers that are there that hold the body part. Sometimes you can autoclave those, sometimes you have to wash them, it just kind of depends. Usually you can reuse the covers for the same patient, but if you're changing it from patient to patient, you want to make sure that you get those cleaned. Quarterly or, so every couple months, make sure that you look at the machine, lubricate any of the moving parts like the joints and the ball bearings and any of the rods. Check the electrical plug, make sure that all is clean and not frayed or any other damage there. And that is it. So again, you have a video kind of watching on typically how to set up CPM, but otherwise this is one of those modalities that you just have to kind of know the reason behind it and how to, in general, kind of set it up, but you don't actually have a competency for it.